Hey, I have 1 o'clock here, so I'd like to welcome folks to another edition of TEPHI Talks, a series that's been developed through the Texas Epidemic Public Health Institute. My name is Bob Emery here at the University of Texas Health Science Center at Houston, and we welcome some really interesting guests. For those of you who joined in previous TEPHI Talks that we've had, we focused on lessons learned regarding the recent pandemic, which now we've endured for 3 years. And we certainly want to compare notes with other individuals and from different sectors that dealt with this. But we're at a point now where we have to look forward. So we're very excited about the speakers that we have today to talk about their previous experiences, but more importantly, strategies for going forward. Before we begin, I'd like to take a few seconds to talk about what the TEPHI program is all about. So I'd like to segue over to the Interim Deputy Director of TEPHI, Dr. Janelle Rios. And Janelle, take it there.
Hi, thank you, Bob, and thank you, our representatives, Parry and Terry from McKesson. Thank you all for joining us. I'm happy to introduce the Texas Epidemic Public Health Institute, or affectionately known as TEPHI. We are a brand new state agency. We have been funded for just barely a year now, and we're moving forward and doing a lot of great work in the state of Texas. Just right quick, I wanted to share with you that we are organized into 3 major cores: readiness, communications, and training and resources. This particular event is coming to you from the Readiness Core, and a few other programs that are in the Readiness Core include early detection programs, particularly with analyzing wastewater samples across the state, data analysis and data visualization. We have a rapid assessment team. We pay particular attention to vulnerable populations and food chain preparedness, and several more things. But this is really what I wanted to share with you today. I'm going to move on to talk a little bit about the Certificate in Pandemic Preparedness and Response. This is part of our training core. It's free, and you just scan this QR code and it'll take you right there to a Contact Us form so that we learn a little bit about you. It's designed for volunteers in Texas, as well as physicians, nurses, other healthcare professionals, school nurses, and it doesn't have to be healthcare. In fact, we're targeting the business community with this particular program because we're interested in giving you the information and the foundation that you need in order to make decisions that'll keep your community, yourself, and your family safe. The program consists of 4 online self-paced courses and 1 capstone exercise, which is also online, but it'll be live. We provide the textbooks via an online link. So that's a really exciting thing, and we're very proud of this particular program, and I hope you all are interested in taking it. A few housekeeping items for this particular webinar. When you entered the webinar, your microphones were muted and your cameras are turned off. Closed captioning is available if that is of interest to you. And I've got all of that recording right now. If you have questions for our speakers, please type them into the Q&A box rather than the chat box, because I'll be monitoring that and I'll be consolidating the questions for our speakers. At the end of this, you'll be taken to a survey. So please fill out that survey. It really helps us figure out what we need to do for our next webinar, which will be in 2 months. You'll also receive that survey via email. So like I said, we are recording this webcast and it'll be available on our website in about a week. And with that, I'm sending it back to Dr. Emery to introduce our speakers. Thanks, Bob.
Thank you, Janelle. So I should have clarified, I guess, before the beginning of this, that I wear 2 hats for the university. Part of the time, I'm the safety guy over the entire university, and then there's my faculty appointment, the School of Public Health. The reason I share that with you is that, as many other organizations, we were grappling with how to respond to the pandemic as it emerged, and a lot of that had to do with logistics and materials and supply chain and the like. And so when we were afforded the opportunity to shepherd this TEPHI initiative along, we were very interested in reaching out to organizations that were intimately involved in that supply chain piece. And we were fortunate enough to make, I think, the key connection with regard to within the giant organization that McKesson is. We were actually able to tap into the folks that are involved in the medical surgical government solutions. And so I'm very pleased to introduce the unusual team of Parry and Terry. That's kind of an interesting combination, but Parry's the senior market manager under the governmental section for McKesson, and then Terry is the senior director for logistics. And so what they're going to do here is to speak to briefly about their experiences, or I guess starting maybe a little further upstream, how they were attempting to anticipate what was going on, their experiences, but more perhaps most importantly is going forward. What are we to think about going forward? Because all of us are in the same boat in this regard. So thank you so much for taking the time to participate with us, and I'll pass it on to Terry at this point.
All right, great, thank you. And thanks for having us on this. I think this is a great program that you guys have. And we're pretty excited to share some of our learnings over the past few years. First, I'm Terry Henderson. I've been with McKesson Medical Division for about 20 years. I spent almost all of that time in supply chain. So working with domestic suppliers as well as international suppliers and all the different logistics components in between. So needless to say, the past few years have been very interesting. Next slide. So just to focus in on what I'm going to be talking about here. We're going to be talking, when I'm talking about products and supply and demand, I'm really going to be talking about PPE related products. I'm not going to be talking about RX or lab products. So I'm really going to focus in on those. And those are really just the kind of the core, some of the core PPE items that we had interaction with throughout different pandemics. And I'm going to focus most of my effort on gloves and masks. It seems like those are the two areas that had either the longest running issues or some of the first issues that we saw. So I think the first thing to point out when you're talking about these types of products is demand is historically very stable. When you can go back years and the demand line for these products is stable. There's some seasonality tied to flu seasons and whatnot, but for the most part, demand may vary, may vary 5 to 20% depending on the year, but it's not huge. And so that's most companies kind of built their plans around that. The other thing to point out about these products is most of them are shared with other industries. So we always think of medical, and I'll use N95s as an example. We think of NIOSH N95s, but the larger portion of the industry that uses N95s is actually industrial. So if you picture it, you're looking at a factory producing N95s. They may have 5 lines tied to construction related N95s and 1 related to medical, because medical is such a smaller portion of the actual demand. Nitrile gloves, fairly similar, probably more lopsided towards the medical industry, but there is a fair amount of non-medical nitrile gloves that are out in the market used for everything from food service to, again, back to some construction type related industries. So when you think about the supply side of this, it's really the supply side has been built around a predictable demand line. And so that variation I was talking about earlier, that 20%, that's normally the supply that is available in the market. So it's not a huge swing. People normally plan to what is actually happening. And that's kind of the basis for the story that we're going to walk into. So I've got an example here on the next slide. So in 2009, a lot of you guys might remember this, but bird flu happened. And what really created the issue here was basically we had a flu season, and then after flu season, we had another flu season. Well, that's not normal. And so that demand change created huge widespread issues. I mean, I can remember talking to domestic manufacturers about masks during this time period. And while they were up and running, and they were running as fast as they possibly could, there was not enough production capacity to support a demand change of that significance. We're talking about 1,000% change in the demand line for some of these procedure masks. So the normal, predictable model just fell apart. But keep in mind, this bird flu or H1N1 was a little bit different than what we've been dealing with over the past few years. We've never seen anything like what we recently went through. So next slide, just to kind of lay the groundwork here on the pre-COVID world for gloves and masks. So this is the actual demand for those two categories. About a third of the total demand is in North America, and the rest is sprinkled throughout the rest of the world, usually based on population or economic circumstances. Next slide. So if you layer in the production over top of that, of these two items, 90% of the glove production is in Asia. And you can actually drill that one in a little bit more. The vast majority of that is actually in Malaysia, where most of the medical grade nitrile gloves are being produced. Masks, about 60% of those were in Asia, and we still had about 20% of those being produced in the US. So totally a different situation here. And I think one of the things that popped out early on the next slide is it looked very similar to bird flu. We had huge spikes on masks and gloves and things like that, all the things that you would need for a pandemic. So that's kind of your first alert. But what actually happened that was a little bit different, if you go to the next slide, is that not only did we have this demand picture shaping up that we knew that production couldn't support, on the supply side, we actually had a lot of manufacturers starting to shut down. And so we had a much smaller, tighter supply at the very same time where we needed a lot more production capabilities. And those two things did not go well together, which created an even bigger, longer problem that had to be dealt with. So on the next slide, there was a few things that you guys probably heard and things that were done to try and mitigate some of these issues. So first was conserve. There were a lot of messages coming out from government entities explaining protocols for conservation. A lot of different groups came up with their own policies, but then a lot of manufacturers began allocations and buy limits. So what would happen is if our normal historical demand for a pediatric procedure mask was 100 cases from a given manufacturer, they would allow us to buy 100 cases, regardless of our demand being about 1,000 cases. So those allocations cut into our ability to support a spike in demand, but it did level out the playing field a little bit. The complexities we ran into is that everybody did it differently. So a lot of manufacturers were very tight on how the allocations were run down to regions and things like that. And some people they're a little bit looser about it. So that was a little difficult to deal with. On the supply side, we had the EUA and some partnerships that came into play. And so this opened up a lot of products that we wouldn't normally be able to sell in a healthcare setting. So I think you guys probably remember the KN95s, which I don't think they're still on the list now, but those were quite popular as N95s ran out. But that program opened up our ability to source things from other places where we hadn't been able to do it before. There's one bad thing that popped out through this, if you want to go to the next slide, is that the entrance of all these new manufacturers, new brokers that had access to products that we weren't necessarily familiar with. We had to stand up entire organizations that were dedicated around proving out each of the products that came through. So that means talking to brokers and finding out where those lot numbers of those products actually came from and making sure we understood the source of those products. There was a lot of brokers that were coming into the market that were taking advantage of the situation. So I had heard of stories of prepayments being required and products never showing up. non-medical products ending up in a medical setting, and even defective merchandise. So gloves with pinholes and things like that. So it was very scary for a little while there, as things like this started to be, as we started stumbling across different brokers that were offering things like this. It was kind of surprising. Next slide. So the other thing that we got involved in was Airbridge. So we had the demand issue, we had the supply issues. So really the other option that we had was to move it quicker. So don't have a whole bunch of inventory tied up on the ocean for 30 or 60 days. So partnering along with some government entities, we worked on Project Airbridge, which was actually, it was pretty amazing. It went on for about 2 to 3 months, and we orchestrated plans to actually move PPE from the factory floor after it's been quality checked by our people, loaded onto flights, and basically redistributed once it got to the US. So instead of it taking 60 days or 2 months to get an order to a customer, we were doing it in 48 hours, which was a pretty powerful change in distribution. We did have to realign the way we actually manage some of these things due to hotspots. And we knew that even with the supply coming over a lot faster, we didn't change the overall production issue. We were just moving it faster. So a lot of that product had to be guided towards hotspots, which we're updating periodically. So with that, I'm going to hand it over to Parry.
Yeah, thank you, Terry. Yeah, my name is Parry Carter. I'm a senior market manager within government solutions at McKesson Medical Surgical. So a big part of my role is identifying market trends, working closely with our product and supplier support teams in order to identify these trends that might impact our business and our customers' operations. And I work diligently to make sure that we're driving the voice of the government customer deeper into the business. So, with that said, Terry outlined a lot of the global issues straining the medical supply chain as a result of the pandemic. I want to take just a few minutes to talk about the pivot from this reactionary state that we found ourselves in to posturing more as a resiliency state. So we'll see here, some of the issues continuing to weigh on the domestic supply chain, and Terry hit on a few of these, but the secondary, tertiary effects too, like diminished labor force, continuing production delays. And it's really been this snowball effect that has forced the US into this so-called resiliency state, which is a positive thing at the end of the day. And so this is implementing go forward readiness strategies to be prepared to respond in the face of an emergency, if that's another pandemic, a natural disaster, or just an unforeseen scenario. And today we've seen across industry and government steps taken to increase visibility and control, decrease risk and waste. Terry hit on, making sure that fraudulent products aren't making their way into the United States marketplace, and folks are indeed getting what they need when they need it. And finally, steps to increase the thoughtfulness around future funding needs for medical supply chain resiliency efforts, right? So that's what we're facing today and how we're posturing today. And the federal government has put in place a lot of measures to increase domestic production of critical medical supplies, if that's through grant programs, for example, or enacting the Defense Production Act or the Buy American Act to address global sourcing problems and risk. And some states are taking resiliency measures into their own hands now. I mean, TEPHI's existence is the perfect example of this, really. And Colorado, too, is now working to implement a statute that establishes a new program to maintain a supply of face masks and gloves and other medical grade PPE that can be distributed to hospitals, vaccine clinics, schools, community centers, stadiums, pop-up clinic, anywhere at the point of care if a disaster emergency is declared. And importantly, allowing clinics and community centers and these other sites, not just hospitals, to operate as point of care delivery sites really means that people can get what they need when they need it. And states like Colorado, I think, are just being thoughtful in how this stuff works in practice, and posturing, again, in a resilient fashion. I also wanted to mention this Colorado legislation clearly defines the department managing the stockpile and the distribution process. So there's no overlap or confusion. So, just this list that we're looking at now is just some of the things that we're collectively thinking through as we're looking at readiness and go forward strategies. And Colorado and Texas are not the only states to think through this. California, Connecticut, and Florida are working on some strategies. And all of these programs really, they serve as good national models because they emphasize the need to monitor product expiration, rotate goods as needed, and prioritize sustainable long-term spending so stockpiles can sufficiently be maintained and used when needed. So from McKesson's perspective, a distribution standpoint, we need to support these federal and state efforts by way of sustained operational supply chain excellence. And that really happens through these transparent public-private partnerships. So entities like McKesson and agencies like TEPHI are now approaching resiliency truly through a readiness lens, which is different than maybe over the course of the last couple of years. Being adequately prepared using forecasting analytics, for example, to make sure these stockpiles are maintained and products are rotated. So masks, ambulatory equipment, infusion pumps, so on, are ready to use. So, without accurate and timely accounting for stuff like this, emergency management teams are really flying blind, and they're unable to determine available inventory, which again, as Terry outlined, that leads to supply shortages, unnecessary purchases, expired items, right? One other thing I wanted to mention on this slide, it's not listed here, but just hitting on health equity and how resiliency positively impacts health equity. I know TEPHI is working to develop and operationalize this work and learn safe protocol structure for small and rural businesses and schools. And McKesson really ties into this too, ensuring that healthcare providers in rural areas are not limited with respect to product selection, particularly during emergencies, right? So that all matters when we think about supply chain resiliency, no matter the site of care, if it's a rural area, excuse me, or urban. But it's unrealistic to think that all of the things that we need will be manufactured in the United States. It comes down to prioritization and understanding what we need and how much, right? And that's the expertise brought into this from the commercial side, I think. And posturing in this resiliency state is really made possible through quality public-private partnerships. So the government can and has reduced barriers in sourcing, transportation, product availability, and that makes it possible to recreate these accelerated programs like Terry had mentioned, Airbridge. Think about a mini Airbridge, if you will, for the recent shortage with baby formula, right? Shoring things up quickly using these models that we've employed in the past. But a lot of the execution of that is left to the commercial side. And so that takes data sharing, production and supply chain assessments, unique inventory management techniques. I mean, all of that helps to play a role in gaining control, reducing risk and waste, and driving down costs. Because the fact is that the federal government really couldn't appropriate enough money to do everything that's needed in the long term. And these public-private partnerships can really bring more certainty into the fold. And I think that's really my key takeaway with my slides here, just given that TEPHI is working diligently to collaborate across industries, with leaders in public health, science, medicine, the private sector, in order to prepare for the next public health emergency. It's really about striking that balance of responsibility between government and quasi-governmental entities and private entities too. So I think that's sort of the key theme running throughout my slides, and thinking about what we're doing here domestically and what the future should look like and how we're planning for that. So I know now Terry has a couple more slides about diversification efforts here domestically. So I'll kick it back over to you, Terry.
Yeah, thanks. So I threw this in. I was down at the Port of Savannah last week and came across this slide, which, keep in mind, this is not medical specific, but I thought it was very interesting. We're all talking about, what do you do? We got caught by having a lot of our nitrile gloves being sourced in a single location. 90% of the world's gloves were being produced in a single area. So, it always gets you thinking, well, what do you do for next time? Like, how do you not get caught in that sort of situation when a particular country shuts down and then all of a sudden you have no access? And so this was a pretty good representation. And again, this isn't medical only, but this is real information. So this is ships coming in to the Port of Savannah in a comparison from pre-COVID dates to recent. And I think the big change here is that things shift slowly, but they are shifting. So you can see that there are some winners and there's some losers in the mix. And so this is just a perfect representation. Is typically you wouldn't see things like this change that often, but they're changing a little bit more frequently. And I bet if I sliced this up and just looked at a difference between 2021 and 2022, there would be a lot of that change is probably taken in that time period. So, I think, if you want to dive into gloves again, because that is one of the areas that seem to cause the most problem across the medical industry. There's been 28 companies that have announced that they're going to be building factories within the US. They take a while to build and produce, but they're actually on the way. So that's going to be a pretty big change. There's some government incentives that are coming in to help support that. But of those 28, 8 are actually up and running right now in limited fashion. Certainly not in the scale that can, that can support the needs of the country and that 1/3 of the total demand that the world has, that is in the U.S. But it's certainly a start, and it gives a little additional supply to help with issues in the future that don't have a long lead time to actually get through. There's a number of those factories that are actually being produced or actually being built in Texas. So I wanted to call those out as well. And there's some of the fairly large players. So I guess with that being said, that is the last of my slides.
Yeah, so I guess if we can stop sharing the screen, we've got questions flowing in, but I get first dibs. But this could be an entire college course, what you've just described. I mean, it's pretty fascinating, and I think to the benefit of the entire state of Texas and the country going forward, these vulnerabilities, but also opportunities. And I've got just a couple of things popped in my mind very quickly, because I'm wondering if you guys are cogitating on this one, and that is this balance, or think of a small business who has endured this issue and gotten through the pandemic, and they're thinking about stockpiling, but you have this balance of shelf life, and how much can I afford to stockpile versus the shelf life. And I actually was making a note with Terry's initial graph with the supply and demand thing, but you guys must have an internal recommendation that you make to customers, I guess, where that balance perhaps has shifted in this environment where and maybe in the pharmaceutical business they've done this, I don't know, but you got that shelf life parameter, and there's some variability in there, and I'm just curious about your thoughts there, because these products that we focused on PPE, but they have a shelf life as well. And how do we, what advice do we give to folks that are on this call about that piece, myself included, put on my safety hat? That's the reason I'm asking.
Yeah, that's interesting. So I guess from a distribution standpoint, we look at it one way, like what can we do to help solve the issue? Because it's the same. You can't invest in 5 years of inventory with a shelf life of 2 years. It just doesn't work that way.
Right.
So, we've tried to increase our safety stocks and also have finished goods at the factory and things like that to try and give us a little more flexibility when things like this happen. We've got a little bit of a back stock that we can pull forward. But from a customer standpoint, I think it is that balance of, if it is a 2-year shelf life, and normally you're keeping what you need on the shelf because of space and whatever. There are probably those key items, the 5 items that maybe you don't keep what you need. You keep, another shelf with some additional inventory that maybe equals something that's on the verge of uncomfortable. Maybe it's a 8-month supply or something like that, something that can get you through if something like bird flu happens, where, there's no real supply side issue, but there's definitely a demand issue. And you're going to end up with back orders that can't be resolved. At least that kind of plan would get you through until the actual product starts flowing again. So I think it's a balance.
I'll tell you where I was going, and I don't want to derail. I mean, we can have a side conversation on this, but when you were talking, it got me thinking about the notion of the highest priority individuals. I would argue would be the frontline healthcare providers working with, in this case, COVID positive patients. That's the tip of the pyramid, so to speak. And as you enter situations where you have to rotate stock out, could there be an ability to rotate that stock to a lower level of acuity? I'm thinking of hazardous waste response. We've got level A, level B, level C. Imagine healthcare providers at level A. Okay, now we're going to rotate the stock out, but there's other industrial applications, as you mentioned, that perhaps meet category level B. You move that to them. I remember, just again, I'm not going to occupy time here, but you have fire hoses in your building that they're for fire suppression, but they also have a shelf life, and so we donate those to the Forest Service. Because they don't really care if the hose leaks that much. They just want to put the forest fire out, right? So that's how we kind of rotate these things out through a tier. And I'm just wondering if you guys have been thinking about something along that line in acute situations, something like a pandemic. I'm not saying do it all the time, but in a situation that we encountered over the past 3 years, we had to make some on-the-fly decisions, as you guys did as well. And I'm just wondering if that's something that had been factored in your playbook.
So it has. And so I think inevitably, as you go through something like this, you guess wrong. And so, I mean, I can remember the early days of COVID, everybody's trying to guess on, well, how many N95s do we need to support the market?
Yeah.
That depends. Are you talking about, is this going to be a 3-month window? Is it going to be a 6-month window? What is it? And so if you bet long, you're going to have a plan for what you have that you're not going to be able to sell through. And it's exactly what you're talking about. It's like, we know we're going to have too much at that point in time. So how do you make sure that you don't throw it in the trash and there's actually a use for it? And so I think that that's pretty common. I think formalizing that into a normal process is something that probably needs a little more work. And it's, I think it's kind of challenging.
It is.
It's almost like you're accepting a discount on a product immediately because there's potentially going to be some issue with it. And so I think that's kind of the fine line you have to walk. And that's what I said, like, if you want to push your stock level on these very specific items to where you're almost uncomfortable with it, but you feel like you can use it, it usually seems like that's more of it's a safer bet. But it wouldn't get you through the situation that we just went through. Right. And I think that's very difficult to constantly being in that stock position where you're waiting for this event to come through. Because at some point, somebody's going to look back and say, we don't need that. We haven't used it in 5 years.
Right. So, well, on the other end of that spectrum, I never thought that we would be in the business of reprocessing N95 masks that were intended for single use, but we were pressed to do so. So it's we're at the very end of that distribution. That I think a lot of the viewers of this video were perhaps not at that very acute end, but they are grappling with, okay, we've kind of heard from these previous talks, we know something's going to come again. We got it. That lesson's been passed along. But now, how do we make a decision from a business perspective? How much of the stuff do we, either purchase and or enter into a contractual obligation to be first in the line with that? So anyhow, I'll pause there. I've got a serious, I could go on for days, but really appreciate your comments, both of you guys. It was very insightful. Janelle, her role is as these chat things come in to kind of congregate them, because oftentimes we get different questions that come in, but they can be bundled together because they're repetitive. Not that that's bad, but it's a common theme there. So Janelle, I'll kick it over to you.
Sure. And this is really related to what you all were talking about just now. The question is, I have a small 2-physician practice with a significant geriatric population in Houston. What are your suggestions for increasing my supply chain resiliency while minimizing costs? And storage costs something, and, rotation costs something. So that's the question. Is there anything you'd like to add?
Terry, do you want to take a stab at that understanding so well, supply chain side?
Yeah, I guess I can take a stab at it. I think that's difficult when it's a smaller practice. I think the smaller you are, the more difficult this situation is. I think my recommendation would be find other people that are in the same situation or other size facilities and go in it together where you have a single plan, which isn't always easy. But I think that's probably, in order to build your scale a little bit and build that resilience, sometimes it's hard to go it alone, especially when it's a smaller practice and with high variability on some of those products. So I think that's probably the best course of action.
Yeah, and that's, with the pandemic serving as a forcing function to think through more efficient vendor managed inventory models. That's sort of the bent, the consultative angle that McKesson has come to, state and federal agencies with. It's just, you get to an equilibrium, a certain amount of products or servicing a certain, a large enough number of people, it begins to, it starts to become easier to think through at that scale, managing inventory, moving things around, so on and so forth. So I agree with that, Terry.
Great. I'll keep on going, Bob. And this is actually my question, going from this very small 2-physician practice to a very large entity like the Texas Medical Center or UT Health. Does McKesson or other suppliers, do you see those differently? Are you perhaps allocating, not that you're the manufacturer, but are you allocating pieces based on size or what are your priorities? Is it based on a geriatric patient population or a more at-risk one?
I think all of those variables come into play. I mean, when we meet with state agencies, for example, geography, demographics, existing points of care that have been set up in the past, large stadiums, arenas. I mean, all of that comes into play because when we think through some of these strategies at this scale, it has to be bespoke for a particular state, like in this example. So absolutely, all of that is on the table and up for consideration.
Thank you. So we have one from San Antonio, from a researcher actually in San Antonio, Dr. Herbold. Do you have a research question that you would like researchers to answer? And I'm paraphrasing there, so that's not exactly John's email that he sent.
Well,
if they don't, I have one.
I'm gonna have to think about it. I wasn't prepared for that one.
Yeah.
Well, it's this notion. I don't know if this is actually an agreed upon term, but the notion of refurbishment. And I realize that's probably not in your guys' wheelhouse because you're sourcing traditionally materials that are single use, although the larger McKesson footprint deals with many other products. I understand that, but I was fascinated by this being forced into the notion of refurbishment for single use products. And that ties into this notion of shelf life. And I'm wondering whether you guys from your perch have considered that, or perhaps there's a need for independent validation for how shelf life might be extended in extreme settings. And I'll bet that's what Dr. Herbold is fishing for there. If he can chat in.
Yeah, I think that's interesting because I know we were getting that a lot of information from the government on what to do about this lack of supply and conservation and reuse of single-use items did come up. From our standpoint, we do have teams that work with production and factories that are making these things, and they're pretty good about what tests need to be employed to validate that different manufacturer dates are okay, or the length of time that it can sit on the shelf. And usually, I think a lot of times when we run into issues, it has to do with sterility and the packaging actually not being good for a certain number of years. And that's one of the key kind of breakdowns on how long something can actually last, is if the requirement is it's got to be sterile, that's difficult. So, but yeah, I mean, I think that's interesting, to get involved in something like that and testing out products to make sure that they're see if their dates need to be extended. I know we did work with some national brand manufacturers around the exact same thing, where they had certain products, and maybe it was even N95s that were coming against a shelf life date, but we couldn't necessarily do anything. We didn't want to buy anything short dated. So, getting into that a little bit more.
Yeah, I think of these concepts of EUAs, emergency use authorization, and then also just in time, just like we do just in time training for folks when something like this emerges, the notion of just in time testing or validation to say this particular product of this lot, we were able to confirm that we can continue using it in these extreme situations. And that's another challenge that I see, and I'd love your guys' opinion on this, is that when you're talking about percentages of 1,000% or 100%, this is very extreme. And some critical decisions need to be made that we're all rolling the dice on that. We're trying to use our best professional opinion on what it is we can do and how much can the limits be pushed to provide compassionate care to the patients and the other operations. But it's extreme territory. I mean, I can't imagine what you were dealing with and the questions that you guys were getting We're being pressured on.
Bob, we're guided by, like in the office, we have posters and things, every package is a patient. And that is a mantra that guides McKesson Medical Surgical, and that was certainly put to the test over the course of the last few years. So you're exactly right.
Right. It's pressures that I think folks don't truly appreciate, that everybody's trying to operate in the best interest and say what is the best thing for the patient or the customer, but there are many pressures coming from different directions. So it's really kind of interesting. So Janelle, do you have others?
Yes, I've got one more. If states like Colorado create their own stockpile, would they be competing with other states or the federal government? How do you decide which efforts are best centralized and which should be decentralized?
Yeah, I've asked this question to folks before too, and there's a lot of gray area here because a number of states, even the localities within certain states have more autonomy than maybe some state agencies in another part of the country, right? So I would just say that I think the federal government, it just must play an overarching role in all of this. It's just kind of the reality of the situation. And there needs to be an effort to develop a coordinated response across relevant stakeholders at the state, local, and federal level. There's just a staggering amount of information and data available, but it's so hard to share it, especially real time and during an emergency. So kind of putting in place some sort of coordinated effort on the front end to help with readiness is an absolute. And I think the first step in that, and I don't know that this is happening much today, but the federal government could serve as a convener for best practices for state and local agencies. And this is a role I could see TEPHI stepping into as well, right? Just kind of understanding boots on the ground best practices, and then leading or working alongside the federal government to make sure this stuff is instituted nationally. And again, that we do have some sort of coordinated effort between these levels of government. So it's a fantastic question. And again, there's a lot of gray area, but there's some give and take.
Okay, yeah. So being part of the School of Public Health, we can assign homework to you guys, by the way.
I didn't know that.
And we'll grade for penmanship. But no, what you just said, I'm thinking to myself, what do you guys, from your perspective, wish Texas had known or had thought about or been aware of when this was emerging? That's kind of a deep thought there. Going back to Terry's graphic showing the world and showing the consumption versus the production to set the societal expectation, understand where this is coming from. And, it reminds me very much of early on the novel coronavirus, but the term novel got dropped. And that became problematic because people didn't, I would argue the term novel set the expectation that, hey, things may change. There's certain things that are known about this virus, certain things that aren't. And it's buckle your seatbelt because the recommendations may change over time, namely the transmission absent of exhibited symptoms. That's a big deal in this business. And so I'd really welcome your comments back on what do you wish folks had known, or what, as we move forward hand in hand, what do we want folks to know, going forward? And you don't have to answer that today because we're going to grade on penmanship because that's a deep question there. So Janelle, do you have any other questions on your end there? Okay.
Yes, I do. It's really not a question, it's a statement. Capitalizing on Shelf Life Extension Program, or SLEP, when conditions are met and assuming prudent risk based on the catchment area by population, demographic, and history of consumption. And here the example is snowbirds, and including the uptick of cases based on the condition. you can create a memorandum of agreement with SLTT and non-governmental organizations. And Arthur is the one who presented that. Arthur, if you'd like to add to that statement, feel free to go ahead and type that in.
But let's let Terry and Perry weigh in, because that was some acronyms I'm not familiar with. So is that something you guys have dealt with, or is that...
It is not from my end.
Okay.
We have other teams, quality and other people that are really involved in shelf life management, as well as they got involved in some of the shelf life extensions that we worked with through the FDA. So not really my area of expertise on that.
Okay. Interesting.
But I can take more homework.
Yeah. Okay. Perfect. Okay. Anything else that you have to note? Nothing on your end? Okay. Okay. I see chat things showing up on the bottom of my screen, but I don't know if those are duplicative from what you have there as well. So.
They're duplicates.
Okay. Got it. Okay. Great. All right. Well, so let's talk about path forward here. Number one, we expect your homework. We'll give you a due date. Want to thank you guys for taking the time. This has provided some really interesting insights and some thought-provoking conversation that I think will help us guide as we move forward. We are continually reaching out to various organizations, and we've tried to target various industry sectors. So, for example, the hospitality industry, we have others that are that loom in the future, but your comments here have caused me to at least think much broader, and the notion of Terry's comment about the percent of non-medical industry folks that are tapping into PPE gets me to thinking that we need to be speaking to these larger portfolio. And I'll pause there and just ask, maybe just off the top of your head, is it oil and gas or all industries? Or that struck me as something we need to look into that we've overlooked. Could you give me a flavor for the consumers of the PPE, those industry sectors?
Mostly construction.
Construction.
Right.
Okay.
If you think about it, like you might see an N95 mask being used by somebody hanging drywall or something like that. So there's a use for very similar products within that type of industry. They're produced a little bit faster because they don't have all the regulatory hurdles of a medical grade device.
Right.
But they're very similar. But yeah, I think that's probably the if you're looking for a potential opportunity, there should be something there. You talk about how much of the volume is actually dedicated to one industry versus another, and historically. So pre-COVID, I think things have changed and protocols have changed, and our storerooms are probably all packed with N95s now. But pre-COVID, it wasn't really a huge need. It wasn't something that was you needed it every day, even. And I think I can even remember in the early days of COVID, there hadn't been guidance around that. People were using 2 procedure masks or 3 procedure masks, or they were kind of doubling up and things like that. So, but yeah, so I think most of to answer your question, Bob, I think most of it is going to be in the construction type area.
Okay. Yeah, we'll put that on our target list. That would be interesting, because the degree of fidelity, so to speak, for someone in that setting versus someone that's direct patient care with an airborne or aerosol transmitted thing is perhaps different. That we'll get down into the scientific weeds about that. That'll be my homework assignment to sort that one out. But that's interesting that probably the baseline product is the same until it's manufactured, and then there's certain degrees of fidelity that are applied to make it medical grade, and the fit testing and all that kind of stuff. So interesting there. So this is fascinating to me. I'm getting geeked out.
Yeah, but no, gloves are the same way. So there's a medical grade glove, and then there's a non-medical grade glove. And through the pandemic, We had seen a number of cases where non-medical grade gloves were being sold. But it's the same. It's they don't go through the full process, and they're not checked to that level.
Yeah. I was once lectured by a guy, a business owner. What's the difference? Hey, Emery, what's the difference between a couch and a sofa? And I looked at him blankly, and he said, $1,000. So, there you go, right? So again, thank you guys so much for taking the time. This is really insightful, and I suspect there's going to be folks sending in questions and comments after the fact, but also this is recorded and shared for others to view as well. And I know that there's some tidying up stuff that needs to happen here at this point, so I'm going to kick it back to Janelle there.
Yes.
Okay. So
just for everybody's knowledge, SLTT stands for state, local, territorial, and tribal. And NGOs are non-governmental organizations. So thank you, Arthur, for that follow-up. Also, I want to encourage everybody to complete the evaluation survey. Once you do that, you will get a link to the recording. And that takes about a week for us to do. Please consider that certificate in pandemic preparedness and response. It's an awesome program. And thank you, Parry and Terry, for all this wonderful information. That's a lot of food for thought. We're going to take that back and probably do some research with it.
Yeah, would really appreciate the opportunity. And thank you all for the thoughtful questions too. Really enjoyed it.
And we'll grade your homework and post it online.
Yeah.
Have a great day, everybody.
Thanks.
All right, thank you.
Thank you.
Bye-bye.